Hello and welcome to OncLive News Network. I'm Tara Petersen. Today we have a special program focusing on the topic of metastatic colorectal cancer. For this multi-part series, OncLive sat down with Dr. Gabriela Chiorean, Associate Professor at the University of Washington and Associate Member of the Fred Hutchinson Cancer Institute. Clinical trials provide an option for many patients with colorectal cancer who have tried the standard therapies available on the market. Dr. Chiorean, a big proponent for patients enrolling in a clinical trial whenever possible, provides her perspective on the reasons why patients may hesitate to participate.
Many times when we see patients with colorectal cancer and we talk about clinical trials to them, they think that clinical trials are for patients that are at the end of the road where nothing else can be done. Let's try an experimental clinical trial. In our practice, we tell patients that clinical trials start from the diagnosis of any stage of a cancer, actually sometimes even with prevention. We have clinical trials for people that have colorectal polyps to enroll them to prevent further polyps and further cancers to form. There are clinical trials for very early stage, rectal cancers, colon cancers, as well as for metastatic disease, first line, second line, refractory disease. So clinical trials basically in oncology usually do not use a placebo. Usually we're talking about standard of care plus minus standard of care plus something new. So when we're talking about having access to a new treatment that potentially has generated interest and has potential to make, strides for improvement in this disease, I am a huge advocate of a clinical trial from this point of view. And of course, we always talk to the patients about the option of a clinical trial, the option of standard treatment, and we encourage patients to know that ultimately they are the decision maker, but that clinical trials are in their benefit.
Care for patients who have earlier stage colorectal cancer is somewhat straightforward and is often done in a community practice setting. However, more surgical expertise is needed in the setting of metastatic disease. Dr. Chiorean spoke to us about the need for multidisciplinary care in more advanced disease.
Patients with colorectal cancer who have metastatic disease, and we all appreciate the benefit that people with metastatic disease that have colorectal cancer may be cured with appropriate multidisciplinary care, are oftentimes referred to specific tumor boards depending on where the metastases are located. If we're talking about colorectal cancer with liver metastases, we are referring patients to our liver tumor surgeons who evaluate the potential for surgery, radiofrequency ablation, cryotherapy, as well as interventional radiology specialists who oftentimes perform radioembolization or chemoembolization procedures for individual patients. So I do think that our patients really truly benefit from a multidisciplinary care because we do know that we can push survival rates from an average of about 3 years for our typical metastatic colorectal cancer patient to an average of 5 to 10 years if we manage to cure, resect, ablate, embolize specific areas of metastases. Very recently, one of our patients with actually colon cancer came to us with a tumor that was apparently resectable, but she wasn't able to have any staging CT scans prior to her appointment. So we really truly didn't know how advanced the cancer was, except we knew that she had a colonoscopy which showed the cancer. Following the appointment, she basically had the staging CT scans which demonstrated 2 liver metastases, which were very small. And oftentimes we think together, is it better to offer a patient first a few months of chemotherapy up front, try to downstage the cancer, make the operation more successful? But again, in very select patients that have very limited amount of cancer, metastatic, oftentimes it's possible to actually start out with resecting the few areas of disease and then embarking into the chemotherapy treatment afterwards. So we immediately presented the patient to our liver tumor conference, and together between the rectal cancer surgeon, the liver cancer surgeon, and the interventional people, we all sat down at the same table, and a week later the patient was in the operating room and had all her visible cancer resected, and now, a month later after surgery, has no evidence of disease. Naturally, we would like such a patient with high risk of recurrence to be offered chemotherapy to prevent recurrence, and that's where my work starts now, trying to treat the patient to prevent her from recurring again.
Every diagnosis of colorectal cancer is different. In the setting of metastatic disease, management becomes even more complex. We asked Dr. Chiorean to share her approach to treatment once a diagnosis is made.
When a patient with metastatic colorectal cancer first comes to an oncologist for an evaluation, first we always look at the pathology report. We want to document the type of cancer, the grade of disease, the status of several genes which we know are important, and those are the KRAS, the NRAS, and the BRAF. And very recently, what became very important for metastatic colorectal cancer is the status of microsatellite instability. Furthermore, we always want to look at the staging. We want to look at all the scans that the patient has had to document how extensive the cancer is. Is it involving only one organ, or are there multiple organs involved? Is it involving the liver, the lung, the peritoneum? Because even when we try to be aggressive with people that have minimal disease and we think they are good surgical candidates, it's very important to know, again, how extensive the cancer is. If the cancer is limited to the liver and lungs, or just to liver alone, we oftentimes start with a course of chemotherapy up front for 2 to 3 months to try to really get a biological response, a sense of the tumor, whether we are attacking it with the right treatment, before taking the patient to surgery. And following surgery, we try to complete an additional 3-4 months of chemotherapy to ensure that an adequate amount of medical therapy was given to prevent relapse. Furthermore, though, if a patient, for example, has disease which is widespread in the peritoneal cavity, and those patients unfortunately have some of the worst outcomes in terms of progression and overall survival, we always engage our intraperitoneal debulking surgeons, who oftentimes offer debulking surgery and intraperitoneal hyperthermic chemotherapy. That very difficult and 12-hour operation is, again, very, very difficult to accomplish, and it's for select patients who a priori are exposed to a course of systemic therapy. So we expose the whole body to chemotherapy for a certain amount of time, oftentimes 6 months, ensure that there is no visceral spread of disease, but then offering the patients the potential of undergoing complete debulking of their cancer that had spread around their abdominal organs. Again, very few people are candidates for this operation, but it's a potential, and it does offer the 25% chance of 5-year disease-free survival. That's very encouraging for people that 2 years ago had no good options.
That's all for today's program on metastatic colorectal cancer. You can see more videos like this right here on OncLive.com. Thank you for watching OncLive News Network. I'm Tara Petersen.